jaundice, very, very common symptoms, but at the same time very important and sometimes very difficult situations to handle. So, because I have been told that we are supposed to actually go with the clinical approach as to when the patient comes to you in the first place, how you are going to handle your patient, how you are going to put them into a good working diagnosis, and how you are going to reach into a proper diagnosis, or at least a proper working diagnosis where the patient can be referred safely to a physician, a specialist, a surgeon, a gynecologist, or whoever it may be. Because the symptoms of nausea and vomiting is actually not pertaining to one system. It is something which is which is present in diseases which involves rather all the systems of the body. Forward. Right. So when I go to completion of my talk, I would be seeing to it that at least at the end of my presentation, your participants should be able to understand the causes of nausea, vomiting, and jaundice, take a relevant history, perform a quick and focused examination, provide symptomatic treatment to a patient with nausea and vomiting, and identify patients who need referrals to the specialist. So this is going to be the objectives at the end of this session. Now, by definition, what is nausea? Of course, when we are going to describe something, it's important we should be knowing what we are talking about. Nausea is the unpleasant sensation of the imminent need to vomit. It is actually when the patient has a need to vomit but not actually vomited, usually referred to the throat or epigastrium, may or may not ultimately lead to the act of vomiting. And how do we differentiate it from retching? Retching is spasmodic respiratory movements against a closed glottis with contractions of the abdominal musculature without expulsion of any gastric contents. Here also there is no vomiting, here also there is no vomiting, but there is a difference. And this is referred to as dry heaves, and in our local language we call it ke ubak aa rahe hain. And what is vomiting? It is a forceful and oral expulsion of gastric contents associated with contraction of the abdominal and chest wall musculature. So before we go on to see that patients present with these things, we ought to know that what can be the cause of these things. So causes of nausea and vomiting. There is supposed to be a sensory input, which may be a pain or a smell which is more unpleasant, or a sight unpleasant something, which influences the higher cortical centers, and there could be something like a fear or so many other factors triggering to it. Memory of something bad can again create a nauseating feeling, something you have experienced in the past. And this influences the higher cortical centers, where the vomiting center in the medulla is stimulated, and the vomiting center, the chemoreceptor trigger zone, that is actually lies in the fourth ventricle, and a reflex is initiated. And then this can come from these sites, this can come from the stomach, small intestine, many diseases associated with that. It can come from the labyrinthine apparatus and come from many other things as well. And it all induces, when the vomiting center is stimulated too much, it induces a vomiting reflex. And when the stimulation is not to a maximal level, it induces nausea. What is the etiology of nausea and vomiting? Visceral stimuli, what are the mediators which are involved there? The dopamine and serotonin is released. This stimulates the vomiting center, chemoreceptor trigger zone. These things are released from that centers as well, and the vestibular input. So it's a repetition of the last slide actually. Now this is somebody who is vomiting there, usually just to keep you a bit active and alive. So when we know the cause, our treatment should be directed at treating the cause. That is the best way to treat. If there is something bothering, if we know the cause, if we treat the cause, naturally the thing goes away. So antihistaminics and anticholinergic drugs are most effective in patients with nausea resulting from vestibular and central nervous system causes, because these are the stimulus which are released, and if you just counterbat the stimulus by these agents, nausea and vomiting will disappear. Dopamine antagonists block the dopamine in the intestines and chemoreceptor trigger zone. Indications for these agents are similar to those for serotonin antagonists, and these are mainly used when the patient has got more of the GI upsets. Serotonin antagonists block serotonin in the intestines and chemoreceptor trigger zone and are most effective for treating gastrointestinal irritation and post-operative nausea and vomiting. I will not go into the too much basics so that you forget the clinicals, but at least this is one idea which we should be knowing of. Causes of vomiting, there are multiple causes of vomiting, but if you group them into certain systems or you group them into certain groups of causes, it becomes easier, because when the patient comes that there is history of nausea and vomiting only, or there is a patient who is coming up with nausea, vomiting and jaundice, you have to differentiate these two groups, and at the same time you have to see whether these patients who have started with nausea and vomiting, are they developing jaundice later on. So for that reason we have to keep certain causes in our mind as to what may be there with the patient, and as we see the patient, we talk to the patient, we can focus ourselves to one way or the other where we can direct our questions to the patient and get the root cause of the symptoms. Infectious causes, all type of enteric illnesses, which may be like typhoid and ulcerative colitis and celiac disease and so many and malabsorptions, malnutritions can induce all these things. So psychogenic vomitings, non-GIT infections, the infection may be lying in the ear, middle ear infections, they can stimulate the labyrinthine apparatus and can produce this nausea vomiting, or meninges are involved, hepatitis and many other infective, rather most of the infectious causes will produce a toxicity in the body and they will create this stimulation of the CTZ and lead to nausea, vomiting. So infections, very important causes. Then disorders of the gut and peritoneal cavity, which is more like a local cause because the food is taken in the gut and there's abnormalities in the gut, and of course it can induce this sort of thing. It can be functional disorders like a lazy stomach, more often seen with patients with gross obesity or patients who are having uncontrolled diabetes long-standing, chronic intestinal diseases, pseudo-obstructions, functional dyspepsias, which we commonly label as acid peptic diseases, indigestions, or if there is obstruction in the gut, or if there are related diseases like pancreatitis, appendicitis, cholecystitis, biliary colic, fulminant hepatic failure, and many other to name. So if you just remember these groups and you remember a few causes, you can work up for more causes of it, because if you just start with the list of nausea and vomiting, it will be a never-ending list. And then causes related to the nervous system. Wherever there is increased intracranial pressure, when the patient has got like again meningitis going on, meningoencephalitis going on, or patient has got like hydrocephalus or causes which can raise the intracranial pressure, brain tumors, SOL, space occupying lesions, brain abscess and all that. Then focal lesions, especially those involving the brain stem and posterior fossa, where the vertebrobasilar system is more involved, cerebropontine angle tumors and those areas are involved, or when the patient has got seizure disorders, migraine, classical migraine even presents with a prodromal, where there is like flashes of light, nauseating, irritability, sometimes vomiting, and later on going on to that specific area of headaches. Labyrinthine disorders, motion sickness, pace sickness, viral labyrinthitis, tumors, Meniere's disease. Then emotional response to unpleasant smell or taste, which is physiological, no doubt, but when it becomes over and above the physiology, it becomes pathological and has to be treated. Psychogenic vomiting, more often seen in young persons who have got some psychogenic background where the emotional instability is present in the family, either because of the interrelationship between the family members, more often seen in young girls, again because of the psychogenic factors which are involved with a certain amount of suppression, and this will react in the way that patient will start coming to the doctor, and one way is psychogenic vomiting, apart from many other psychosomatic disorders. Then anxiety disorders, depression, anorexia nervosa, where the patient would like has got a disturbance of the body shape and they would like to eat. There is a binge eating. In anorexia nervosa, they will have less to take, and whatever they're taking they will vomit. But in bulimia nervosa, they will be eating too much and then they will be inducing self-induced vomitus, and that is again manifested in the form of like too much vomiting will lead to acidity over the teeth, and the configuration of the teeth will be different because the teeth because of the acid stains. You can pick these things up in these again young individuals and more often girls. Then endocrine disorders, metabolic causes, uremia, very common in diabetics as well as non-diabetics. Hakim induced, so many patients come up with renal diseases. Whenever the urea level rises in the body and the kidney function goes down, the patient will be coming up with nausea, vomiting. More often the patient may not be aware that they've got a renal disease. It happens very commonly, and when patients come up to us and we try to, when we see the patient, naturally there are other factors. Even by seeing the face of the patient, you can sometimes diagnose renal disease, because the renal facies is very typical in advanced cases. But the patient may not be obviously giving history of passing less amounts of urine, because again our public, they don't take too much water. They're more very much fond of taking like 7-Ups and drinks, even very low socioeconomic class. When you talk to the patients, they say, well, I don't feel like taking water. just 7-Up पी लेते हैं, पानी नहीं पी सकते हैं ना, थोड़ा ही पिया जाता है, खाने के साथ पी लेते हैं, even in the hot weather. So there are so many triggering factors, and with that, when you come up to know the patient may be actually in a state of uremia, or in a patient with diabetic ketoacidosis, sometimes nausea, vomiting, and the first diagnosis is made of diabetic ketoacidosis because the patient was never diabetic, never diagnosed, and went on asymptomatic, and later on one triggering factor like an acute infection, patient running fever or something going on like that, or the blood sugar rising too high will bring the patient with nausea, vomiting, abdominal pain, dehydration, and you can just diagnose that this patient is suffering from DKA from other relevant points in the history. Then diseases like hyperparathyroidism and hypoparathyroidism, with the calcium metabolism is altered, hypercalcemia or severe degree of hypocalcemia with altered phosphate levels can also induce these patients as nausea, vomiting. But these are very rare entities. Hyperthyroidism, the patient is in a hypermetabolic state, hyperdefecation is there, but nausea, vomiting usually doesn't come up, but when the patient is also becoming hyperpyrexic, then this factor triggers on top of hyperpyrexia and leads to these symptoms. Addison's disease, the diagnosis is built up on nausea, vomiting, and loose motions. With, of course, the patient will be having like postural drops, history of falls, and other additional factors. Pregnancy, when the vomiting becomes too much, called as hyperemesis gravidarum, usually in the first trimester, but sometimes it goes even up to the 5 months. Acute fatty liver of the pregnancy can induce this thing. Have to keep in mind if the patient is pregnant. Medications and toxic etiologies. So many medications. The first side effect is nausea, vomiting, anti-tubercular, and antibiotics, and so many others. And toxic etiologies. And then post-operative nausea and vomiting is of course a well-known entity when the patient has had the operation, and later on patient starts up with nausea and vomiting. We've got to look into the causes. Then miscellaneous causes, acute myocardial infarction. Acute myocardial infarction does not always present with chest pain. This is called as what is called a silent infarct. This occurs in patients who are above the age of like 50, or patients who are diabetic, or patients who have got uncontrolled hypertension, or patients who have got autonomic neuropathies. They don't have the feeling of pain, and the patients may just come up with sometimes nausea, vomiting, or patient may come up with sudden attack of breathlessness or with an extreme degree of fatigue, and when you work up this patient, they come up to have an acute infarction. Congestive cardiac failure, congestion everywhere will induce nausea and vomiting. Hepatic congestion is there, gastric congestion is there. Prolonged starvation will tunes the stomach and all the secretions are drying out, and when the patient starts taking something, he is not tuned to that sort of thing and starts having nausea, vomiting. Pain, including cardiac, abdominal, pain anywhere in the body can stimulate a reflex which can induce nausea, and if it is of a severe degree, it can lead to vomiting. So with these things in our mind that all these things can induce nausea and vomiting, we are not talking of jaundice at the moment, we're just talking of nausea and vomiting. So how do you go about with the history of the patient? Ask about the duration of nausea and vomiting. If it's a smaller duration, of course the disease is not going to be too much chronic and you don't have to go with the big diagnosis that we've already discussed. But you have to think that if it is acute, what are the few causes which you have to think of, like acute gastroenteritis, acute pancreatitis, acute cholecystitis, or is it a drug-related side effect, or is the patient having fever, diarrhea, myalgia, virals. So these are a few symptoms which you can act if the patient is having an acute attack. If it is more than 1 month of duration and the patient is coming up with a chronic history and it's an on and off nausea, vomiting going on, you have to think, is the patient having a partial mechanical obstruction, which is very common in this part of the world. The patients having abdominal tuberculosis with mesenteric lymph node enlargement. We have seen lots and lots of cases, and this leads to fibrosis and subacute obstructions. Sometimes the patient will pass the food forward and sometimes the patient will have vomiting going on. Apart from other causes, intracranial processes are there. Patient has had a chronic hydrocephalus, a patient has got a relapsing meningitis. So these conditions can come up with having a recurrent nausea, vomiting. Or if there is a motility disturbance again could be functional or could be mechanical. And patients like irritable bowel syndrome, usually they come up with disturbances lower down, but sometimes those patients also have got an upper GI upset going on and the whole gut is sometimes involved. Patient do present sometimes with nausea, vomiting, but at the same time if there's disturbances because of the mechanical blockade, it can lead to this type of thing. Then metabolic, endocrine, psychological causes has to be looked into. Ask about the timing of nausea, vomiting and the relationship to meals, which will give you information whether this is something like in the gastrointestinal tract or is it extra gastrointestinal, so that at least you can have some working diagnosis before you. Is it early morning before eating, where pregnancy, uremia, alcoholic ingestion, increased intracranial pressure, post-gastrectomy patients with bilious vomiting and post-nasal drips, all these things are most common. Is it during or soon after a meal, where it could be psychogenic, or it could be peptic ulcer near the pyloric channel, or it could be acute gastritis like, where the patient takes something and the inflammation is there and the patient starts vomiting. Or is it a delayed vomiting, more than 1 hour after taking the food? Is it a gastric outlet obstruction? It could be primary if the person is a child or young age, but it could be secondary. We have seen a lot of secondary gastric outlet obstructions. It occurs sometimes when there is duodenal ulcer going on with cicatrization, fibrosis, and getting a secondary gastric outlet obstruction. Or sometimes patients come up with like history of intake of corrosives like bleach or other things, and if they have saved their esophagus, sometimes it trickles down as far as the pylorus and causes obstruction. We have seen again patients where we have given them a surgical opinion and effectively patients have been managed. Motility disorders of the stomach, which could be again gastroparesis, gastropathies, diabetes, or post-bigotomy gastroparesis. If it's more than 12 hours, then again you have to think that the food is going down and causing some problem. Is it a gastric outlet obstruction or is it an atony of the stomach? Ask about the nature of the vomitus. Is this projectile? This used to be very much like for an undergraduate, but again still holds, at least we should be knowing that without nausea, increased intracranial pressure. Is it a continuous vomiting where it's more of a conversion disorder? Conversion disorder is actually an extreme form of psychogenic disorder where the forces of the mental forces, they change themselves into the body forces and induces in one way or the other. There are many manifestations of conversion disorder, but sometimes it does come as continuous vomiting. Very difficult to treat. Habitual, postprandial or irregular vomiting can occur in cases of depression. Regurgitation of undigested food can occur in eclasia or esophageal strictures or Zenkel's diverticulum. Vomiting of partially digested food several hours after meal, free of bile, again gastric outlet obstruction. Or fecal odor is there, and small bowel obstruction is the cause. Then ask about associated symptoms. You have asked about nausea and vomiting. Now you are trying to focus yourself as to which system may be involved. So abdominal pain, fever, weight loss, diarrhea, headache, vertigo, ataxia. So at least you can lead to which system is involved now. If there is an abdominal pain which is preceding vomiting, is it an organic lesion such as obstruction with small bowel, pain typically prominent, severe, colicky, or significant weight loss? Think whether the patient is having an underlying malignant disease or the patient is not absorbing because of this pyloric obstruction. Then ask about the nervous systems, headache, vertigo, neck stiffness, focal neurological deficits, classical brain tumor headaches, severe, worse in the morning, associated with nausea, vomiting, occurs in a minority of patients. Intermittent episodes of vomiting in association with migraine, cyclical vomiting syndrome. So you have to now focus which system is involved so that we can go ahead with that approach. Then ask about amount and duration of alcohol consumption, because many diseases associated with alcohol, gastritis, alcohol hepatitis, and can also lead to this type of syndromes. Ask the women of childbearing age about the menstrual period. Ask patients about the current medications, whether the drug is creating this problem, and about any recent changes in their medication regimen. So if any new drug is added, we have to look into it. Ask about the presence of comorbid disease, including diabetes, renal, ischemic heart disease, peptic ulcer, polylithiasis. And ask about prior abdominal surgery. Is it a post-surgical or is it secondary obstruction with gut surgery already carried out? If you suspect an eating disorder, ask about self-image and binge eating. Naturally, we have got to assess the psychological component. So I think that is enough time given for the history, and then we go ahead with the physical examination as to what we can find in these patients. So just as we start the physical finding always, the general, we look for the vital signs and then go for the systemic examination. In general, because we are talking of patients nausea, vomiting, jaundice, so if you find that patient has got jaundice, then your suggestive diagnosis will be either towards the liver or towards the biliary tract disease, or it's not included here, but you have to think whether the patient has got any disorder related with the bilirubin levels, which means that the RBC pathologies, patient has got like hemoglobinopathies or enzyme deficiencies, G6PDs and so on, which we have got a slide I'm going to show you. And then ask about the mental, when you're doing the general physical, see abnormal mental state, patients with CNS disorders, decreased skin turgor, dry mucous membrane, oliguria, signs of dehydration. So there could be sunken eyes when the patient has got dehydration, and the tongue will be dry, so you have to ask for the tongue, and you have to see the skin turgor, you have to palpate the axilla, and there will be a postural drop in the blood pressure. So signs of dehydration, in general you will see the signs, and later on if there is dehydration, you will go ahead with the blood pressure management. Vital signs, if the patient is febrile, fever, you have seen that patient is running fever, you have to think of some inflammation, which could be infective inflammation, or it could be related to diseases like malignancy, autoimmune, non-infective. orthostatic hypotension for dehydration and hypovolemia. And then you'll see for the pulse, if the patient has got a tachycardia, the tachycardia will indicate that decrease in the blood pressure without increase in the pulse and standing will be seen in patient with autonomic neuropathy or those taking beta blockers. All right. So that is when you're checking for these patients. Bradycardia, large or inferior MIs. Like we talked about these causes. If the patient is having bradycardia, then the patient may be going into a state of decompensation, or the patient who has got severe jaundice can have bradycardia, and that is because of the deposition of bilirubin in the AV node. So patients can have bradycardia with severe jaundice, and this is not a very good sign as well. Tachycardia patients can have, the patient is having nausea, vomiting, jaundice, but of course we are looking for other causes. So if patient has got something related to the liver disease or GI bleed, then of course there will be a compensatory tachycardia, or if the patient is running fever, there could be a proportionate tachycardia. But if the patient is running fever and the tachycardia is not proportionate with that, 1 degree rise in the temperature, 1 degree Celsius rise will give rise to 10 rise in the pulse rate. So if the pulse rate is not rising, but the temperature is rising, we call it relative bradycardia. And you have to think of causes that we discussed, like raised intracranial pressure, causes of it, or the patient may be having like enteric fever, or patient may be having a viral fever, which you have to focus upon the area involved. Then coming to the system examination of the abdomen. If you find that the abdomen is distended, you can think that this can be bowel obstruction, gastroparesis, ileus, or even fluid or the pregnancy. All those causes should have to be taken into view. Patient could be cirrhotic, or patient could be pregnant with this nausea, vomiting. Left upper quadrant fullness, gastric distension, again this causes surgical scars or hernias. You have to think for bowel obstructions. Abnormal bowel sounds are there. High-pitched rushing sounds suggests there is obstruction, and absence of sounds suggests that there is ileus. And sometimes there are just tinkling sounds in the abdomen, which is more common with irritable bowel syndrome. It's going on, but it's tinkling. It's neither too rushy nor it's like an ileus. Succussion splash. You ask the patient to drink a glass of water, and you vigorously shake the patient from both the sides, and the next the examiner puts a stethoscope over the abdomen, and you can see a gurgling succussion sound there. And another method is that you ask the patient to drink a glass of water, and as the patient is taking the glass of water, you're just putting the stent there, and you can hear the gurgling as if something is already filled with water or fluid, and you are adding more fluid to it. So succussion splash is a good sign, and I think in practical sometimes very interested in making you elicit these signs. So this indicates that there is some retention of fluid or food particles, or there's a gastroparesis, a lazy stomach, or there's an outlet obstruction. So this is the diagnostic clue if you have picked this thing up. Peristaltic waves can be seen if you just expose the patient, make him lie down and see for it. You can see 1 or 2 waves passing over the stomach or over the intestines, and if the peristaltic waves are there, then it means over the stomach, it means that there is an obstruction in front of it, which may be the gastric outlet obstruction. Then hepatomegaly, if the patient has got, well, in acute hepatitis there is not usually hepatomegaly until few days have passed. It still holds true for acute hepatitis, but it's not on the very first day. If the patient has come up after 5 or 7 days, there is acute distension of the liver with pain over the capsular stretching, so there is going to be a tender hepatomegaly. And patients with diabetes, many causes of hepatomegaly here. Patient may be on sulfonylureas, patient may be on drugs which may be causing drug-induced hepatitis, patient may be having fatty infiltrations of the liver. Alcohol abuse, again fatty infiltration may be there, alcoholic hepatitis or alcoholic cirrhosis will be there. Malignancy or congestive heart failure with congestive hepatomegaly. Tenderness, acute abdomen, pancreatitis, all kinds of infective elements will be there. Hepatitis and ectopic pregnancy, pyelonephritis, appendicitis. Peritoneal signs, appendicitis, the peritoneal area over the inflamed viscera will be stretched and would be painful. So if it is cholecystitis, there will be signs more pertaining on to that area. The right hypochondrium, appendicitis will be blurred out. And if there is a perforated viscus, there's no time to lose. You got to see the guarding rigidity and immediately you have to work ahead. Then the examination of abdomen doesn't complete if you don't go for an anal or a rectal examination, and you have to see if there's any gross blood or cut blood in the finger staining of the stool, mucosal injury from ulcer, ischemia or tumors. Neurological, you have to see with the fundoscope if there's evidence of papilledema, again evidence of intracranial pressure rise. Nystagmus, where you just ask the patient to focus on a fixed point and you see if the movement is more than 3, it's a pathological nystagmus, and you have to see whether this is because of vestibular or cerebellar disease and go ahead with the diagnosis. Then gait ataxia, again nervous system disorders will lead to gait ataxia. If it's a frontal lobe, there's going to be a small shuffling, a gait, apraxia, hesitancy to move. If it's a hemiplegia, there could be circumflexion on one side and many other gait abnormalities associated. So, and there, this is not actually the very complete examination. You can go with the other systems as well. For example, you have to see the ear for otitis media, you've got to see the eyes. But again, because the time is limited, so we are just going up with the very important points. Investigations. So investigations usually always guided by your history and physical examination. By the time you complete your physical examination, you should be able to assess as to what is really wrong with the patient. Otherwise, the list of investigations will also be ever-ending. So if you think that there's something pertaining to the abdomen, you will focus more on those investigations. If you think it is related to nervous system or it's related to something clue in the ear, like otitis media, you picked up certain points in the history, you're going to go ahead with that. Usually we start with the complete blood count, and here you will see when the patient is vomiting with dehydration, then the count may be over. But at the same time, if you think that there is no signs of dehydration for the patient and the vomiting is not too profuse, you have to look for an infective process. So your investigations actually are based upon how you are taking the patient and what physical findings you have seen over the patient. And anemias and other things, GI mucosal diseases and so many others like blood loss anemia and iron deficiency and malabsorptions, and so many factors will come into play. After doing the complete blood, you just go for the routine tests like the serum electrolytes. In severe or chronic vomitings, you will see that again hemoconcentration will be there, hypernatremia will be there, metabolic alkalosis, and with this you may see some abnormalities there. Then this urea, again a mild rise because of the dehydration, which is more of a pre-renal thing. But if the patient has got a renal disease or if there is an upper GI bleed, you have to see that what is the cause underlying it. Serum albumin, pre-albumin, transferrin levels, usually we don't do all these tests, but we do the serum proteins and we go for the serum albumin levels there. And if the patient has had a chronic history of nausea and vomiting, the proteins are going to be decreased because the patient is not absorbing anything, and the patient is actually not retaining anything and not absorbing. But if the tests come to be completely normal and patient is giving up this history, we have to retrospectively see that how much is truth in the history, because if investigations are all normal and patient is not vomiting in front of you or nauseating, you have to weigh your findings with the investigations. Urine analysis, again if the patient is having ill appearing and dysuria, flank pains, you have to think that whether the patient is having a renal disease or a diabetic ketoacidosis or the patient has got something else behind it. So ketones and glucose suggest diabetic ketoacidosis, positive nitrites, leukocytes, white cells, bacteria indicates that there is going to be infection in the renal tract. ECG, ischemic heart disease, you have to see whether the patient has got like an inferior wall, sometimes inferior wall MI because it is lying very close to the diaphragm, the patient will be having epigastric discomfort and vomiting. So more of the inferior wall MIs are diagnosed by abdominal symptoms, or if the patient has got a large MI. Then you go for the abdominal series. If you suspect small bowel obstruction, you do an upright X-ray, you see the gas, dilated small bowel, and if there are more than 3 fluid levels, you diagnose the obstruction. Abdominal ultrasounds, hepatobiliary, renal, so many, everything can be actually diagnosed, even ectopic pregnancies and pelvic and so many other things can be diagnosed. Then if you think that you have to go ahead with the abdominal CT, then of course you can go, if you suspect that there is a tumor mass or there is abnormalities in the gut or there is a obstruction in the gut, you can go ahead to find the cause and site of the obstructions. Then these things are actually not usually done now, gastric emptying tests and all. CT or MRI of the head, where you think that the process is in the nervous system, in the posterior fossa, or you think that if the patient has got a space occupying lesion or hemorrhage or even meningitis or herpes simplex, all these things can be picked up by MRI. If you think that there is something local in the GI tract, you can go for an upper endoscopy, which is not a very difficult diagnosis and which is quite commonly done. So once you have gone through this array of investigations, then of course you have to treat. And for treatment you always have 2 options. One is that you do a supportive or symptomatic treatment because the patient wants to get better. And number 2 is you go for the specific cause for it, so that at least you can make the patient better for a permanent or for a longer duration of time. But if you just start working on your diagnosis and not give attention to your patient, you will lose your patient. So treatment nauseous vomiting ideally involves the correction of underlying cause, but when the cause is not known, symptoms still can be treated. But here also, first symptoms, address the symptoms and at the same time keep on correcting the underlying cause as much as possible. Targets of therapeutic modalities. The neurotransmitters frequently implicated in nausea vomiting are these 4. And this I already showed you in the very first slide. And so for how you address this 4. Antihistaminics, you can go for this group of drugs. Dopamine antagonist, very commonly used, chlorpromazine, which is now of course less commonly used because of the hepatic toxicity and the effects. Domperidone, which has got least extrapyramidal side effects. Metoclopramide, very good. Prochlorperazine and promethazine. And anticholinergics, you can go for these drugs. Sometimes you have to go as far as steroids is concerned. If the patient has got Addison's disease, or patient has got something to do with cortisol insufficiency, or patient has got life-threatening conditions where you have to go on for steroids. Serotonin antagonists, again, these drugs are not very commonly used here, but this is a group worth mentioning. Then how do you select your antiemetic? By clinical situation. Now you have dealt with your patient, you have taken the history, examined the patient, investigations has been done, and now you have come up to a certain conclusion. By this time a conclusion must be drawn, a working diagnosis. If you think that this patient has got a migraine headache and this is inducing this nausea vomiting, then you have to address by giving something which is to help with these dopamine mediators, and for this you can go on for this group of drugs. Vestibular nausea, antihistaminics are very helpful because histamine release is there, so antihistaminics. And acetylcholine, so anticholinergics are helpful here. Pregnancy induced, the cause is not very well known, but here you have to be very careful. And ginger actually helps a lot because in pregnancy, in the first trimester, very difficult to give antiemetics. They have got so many side effects and you don't want the baby to have adverse effects. So for that reason, you have to be a bit careful. Sometimes you have to tell the mother, you have to console, counseling, and you have to make the meal hours small morsels at shorter intervals and postures and so many things. But sometimes ginger helps here, and even ginger capsules and ginger tea and so many things are there, and this is not harmful for the baby as well. Gastroenteritis, you have to take first-line drugs, dopamine antagonists, and here we have a drug which is called as itapride, and I think some of the GPs will be around that I carried out a study on it as well by the name of Caraton. So that's quite helpful in certain situations. Second line, you can go on. And it's not very, well documented in children because given in adults. Post-operative, again, you can prevent by giving this antagonist. Major adverse effects of antiemetics. If you give antihistaminics, patient will have sedation, urinary retention, blurred vision, exacerbation of narrow angle glaucoma. So you've got to be careful of all these things. And if you give dopamine antagonist, again, some degree of sedation, extrapyramidal effects, QT prolongation. But itopride, they claim, there was a drug by the name of Clebon, if you know, by cisapride, and that used to cause a lot of QT prolongation and has been actually removed from the market. And after about 10 years, this drug has now come up and they claim that there's no QT prolongation. There's another drug by the name of levoprate, and that does have still some degree of QT prolongation. Severe hypotension, rare seizures, granulocytosis, so you've got to keep the blood counts, and if the patient contracts some infection during that course, you've got to go ahead with that and stop the medication. Neuroleptic malignant syndrome, very rare blood dyscrasias. And then serotonin antagonist, again the side effects of cardiotoxicity is there. So that was nausea, vomiting with or without jaundice, and now we are coming up to jaundice. But I'm not going to teach you viral hepatitis, by the way. Just a very brief, erythrocytes breaking down heme, bilirubin, conjugated in the liver, and then excreted via the bile to the intestines, and little bit absorbed through the urine, urobilinogen. So if we know this pathology, we will come to what type of patients we are dealing with. Classification, three big classifications: pre-hepatic, hepatic, post-hepatic. When you're talking of liver, it's more of hepatic. When we are talking of pre-hepatic, it is the RBCs in the blood which we are talking. And if we're talking of post-hepatic, we're talking more of the biliary, gallbladder and the biliary. Intrahepatic causes of conjugated hyperbilirubinemia. I will not go into the details, but you can have a very quick look because otherwise we will be moving off the track. Extrahepatic causes of conjugated hyperbilirubinemia. So extrahepatic, in the ductal system, gallstones, surgical strictures, infections, and malignant pancreas, lymphoma, especially in the porta hepatis and pancreatitis. So all those coming after the liver. Now, jaundice with nausea and vomiting can occur in conditions where the liver parenchyma, biliary or RBC associated condition. This is just the thing I told you. Now, what is important in this group of patients when the patient is coming up with jaundice? You have to see what age group you are dealing with. Is the patient neonatal, child, adolescents, adult or elderly? This is actually very, very important. Why? Because the cause of the jaundice will vary in all these conditions. And neonatal jaundice, to be very precise, is not always physiological. So it's not always that we say, oh, it's neonatal, it's going to wipe off after 3 or 4 days, not to worry about it. There could be causes which can prove fatal. There could be causes which can lead to neurological deficits, cardiac and there could be causes which may be just advancing, and there could be death of the baby if not treated in time. So it has to be actually taken up seriously, and I've got a few slides where I will give you more details of it. Then in a child, again the causes is different from where you take an elderly patient with jaundice. So more of the infectious like hepatitis A, or the patient is having like G6PD, or patient may be having like diseases which are chronic hemoglobinopathies. You have to take like sickle cell anemia, thalassemias, and so many other causes pertaining to it. We will at this moment just remember the age group, and we will come to details as to which age group is more prone to which of the diseases. Adults and elderly, I think you are all aware of that. Of course, many diseases can occur here. Elderly more prone to, apart from the infectious and other causes, malignancies become much more commoner. Then you have to see the place of origin, because this is an MRCP GP program. It's not only patients in Pakistan. You may be seeing patients, they may be giving you scenarios of South Asia patients, and the diseases of geographical origin are of interest, because like in Gulf we see lots and lots of sickle cell anemias and thalassemias and lots of hemoglobinopathies, hemoglobin H disease and SC disease and whatnot. So for that reason, it's important that you know that which is the place of origin. If you get a scenario of this type with nausea, vomiting, jaundice and some other symptoms, and you think that they fit into these syndromes, so you have to see that which area the patient really belongs to. So sickle cell anemias, G6PD deficiency, thalassemia, again they all fall into the child and adolescent group mainly, because if there is a deficiency, it will be picked up by the adult period. It will not go up to elderly. So never write an elderly patient if coming up with jaundice or G6PD. It's going to be either a child or an adolescent. Thalassemia, again the same group, and sickle cell anemia. I have seen babies 6 months of age with sickle cell anemia when I was working abroad, and they used to come up with like swollen fingers. So the disease has to be quite different. And these patients, they go into hemolytic crisis when they come up with jaundice. Usually they will not be jaundice. There are a lot of crises in this patient, like veno-occlusive, aplastic. But when they come with hemolytic crisis, the hemoglobin drops down, the patient is jaundiced, nausea, vomiting, and patient may be ill looking like that. And G6PD will be precipitated by certain drugs, antioxidants, antimalarials, sulfonamides, antibiotics, and even by stings of wasps and venoms. And thalassemia is also present in our part of the country, so we know more about thalassemias. Again, it's a hemoglobinopathy where the patient will usually come up with like broadened cheeks, frontal bossing, and thalassemic facie is very typical if the patient has got a thalassemia trait or patient has got an aggressive disease. So this is more like a thalassemia. And this is the blood picture of G6PD deficiency, where you can see when the deficiency becomes acute and the patient is precipitated with a hemolytic crisis, the cells all start breaking down. So there's schistocytes and all broken up, fragmented cells. And this is a sickle cell. When the patient's hemoglobin, oxygen content goes down with hypoxia, the cells start sickling, and then it leads to this type of crisis, which could be occlusive or it could be hemolytic. Then ask about the onset of symptoms. Is it acute or is it chronic? Is the history of short duration or long duration, which is going to give you a lot of clues. Ask about the prodromal symptoms, whether prodromal symptoms are present or absent. If with jaundice you get prodromal symptoms, you're usually seeing that this patient will be more or less in a hepatitis. Is it a viral or a non-viral hepatitis? That is the next thing to decide. And what is a prodromal symptom? Before the patient actually comes up with jaundice, patient will be coming up like with all right. Arthralgias, fever, joint pains, and then a feeling of ill health, and after sometimes the patient starts developing jaundice. Then you have to see, is it the first presentation or is it relapses occurring again and again? Is it a chronic onset of the same disease? Is it a part of the outbreak in that local area? Because sometimes the patient has got an endemic or a pandemic in one area going on, an endemic going on in that area. For example, hepatitis A is sometimes very common, like sewerage, and like recently we have heard that so many people died of gastroenteritis because of the sewerage leakage in Faisalabad and Hyderabad and Karachi and areas like that. So if you do have a local cause for that thing going on, then you can be more pertaining that this disease is of the same variety where you are already seeing the patients. Examination of the patient, go for the visual survey. Is the patient ill looking, febrile, jaundiced, and dehydrated, stigmas of chronic liver disease, evidence of portal hypertension. If you once quickly do a visual survey, you will come to know which patient you are dealing with. And you can see a jaundice over the sclera. There is where you look for jaundice, under surface of the tongue and skin. Pulse, already I told you, bradycardia, tachycardia. The stigmas of chronic liver disease you already know, but do look for all these signs. Signs of portal hypertension, look for ascites, splenomegaly, shrunken liver, caput medusae, and hemorrhoids. So this is gynecomastia. Here you can see the jaundice going on in the patient. Palmar erythema. Palmar erythema you see on these areas. Sometimes they kind of ask you in the viva. So this is not the area for palmar erythema, the central part. Here you look for deputrance contracture. Again, that occurs in alcoholic cirrhosis much commonly. And you can see the distended abdomen with the abdominal veins quite prominent. You have to see the flow of the blood because you have to see the portal hypertension and where the blood is flowing away. Again, another condition. And this is, what is this? Yes? All right. Yeah, you're right. So provisional diagnosis. Now this was the patient with liver disease. So in liver disease, there are many liver diseases, but for general, pickup of the patient, viral hepatitis of all types, A, B, C, D and E. I don't know why they've not written D. D is the delta, which is incomplete, it falls on B as well. Then drug-induced, alcoholic, autoimmune, primary biliary, leukoid hepatitis occurs more commonly in patients with SLE, but can occur in isolation as well. Wilson's disease, where the copper metabolism is there, and hemochromatosis, where the iron metabolism. Diseases of the biliary tract could be cholecystitis, lithiasis, tumors, or CA head of the pancreas. Then provisional diagnosis associated with RBCs, hemoglobinopathies, already told you, deficiencies, or it could be a drug-induced hemolysis. You have to keep that in mind as well, or hereditary spherocytosis, where the cells are becoming more spherical rather than the biconcave disc, and these are more readily broken up in the spleen, and patient will come up with a triad, or more commonly gallstones, splenomegaly, and jaundice. And again, these patients go into hemolytic crisis quite commonly. Then investigations with jaundice patients are coming up, all CBC, ESR, liver function test. I think you already have lots and lots of things on that. But what I want to emphasize here in liver function test is that if the only bilirubin level is raised, then don't worry too much over it, because it means that either the patient is having like Gilbert's or something like that. And if the patient's liver function is all, the enzymes are normal, the protein is all normal, PTA, PTT is normal, not to worry about it. But if the patient's enzymes are raised, like SGPT and SGOT is raised, then it means that there is a transaminitis, this inflammation of the liver, and this more commonly occurs with drug-induced hepatitis, autoimmune hepatitis, and it also more commonly occurs when the SGOT is more than the SGPT. There is more of alcoholic. If the reverse, it's more of the viral hepatitis. And if the albumin is low, it means that the patient has got a chronic disease, because in acute setups, the albumin is not going to be impaired. I've already discussed, see if the patient is having blood sugar, not only for diabetes, but when the patient has got an acute liver disease, because liver is the storehouse for glycogen. So sometimes there will be excessive release and sometimes there will be very little release. So patient will go into fluctuating states of hyper and hypoglycemias if the patient is more acutely ill. And if the patient is diabetic with a liver disease, never try to give too much of insulin, because these patients, if they have a hypoglycemia, then they're really going to have it. So just keep the blood sugar at a safer limit and at a little higher level. That is how it should be dealt with. Urea, creatinine, urinalysis, and this, I don't think now have time for discussions of these things. Risk factors for hyperbilirubinemia in newborns, that I told you. There could be maternal factors associated with that. If the patient has got an RH incompatibility, breastfeeding, breastfed milk induced jaundice is another phenomena, and there sometimes you have to add the patient bottle feed along with the milk feed. But what is important, that this is more of physiological, and if the patient starts getting better, then of course you don't go with the other treatments. But if the jaundice becomes worsened or deeper, then you have to look for the causes, or it could be because of gestational diabetes with the maternal illness, neonatal birth trauma, cephaloma, hematoma, bruisings, instrumental deliveries. This all can lead to transient increase in the bilirubin levels. But again, this will come down because this is going to be settling down with the growth of the baby. And drugs can cause excessive weight loss after birth, can lead to hyperbilirubinemia, infections, and some other causes. But what is important, toxicity in the newborns, it should not be taken as very lightly. If the patient is coming up with early, these are the signs with which the patient will come up. If it is a bit late, and the chronic bilirubin toxicity, what is more, alarming for these newborns is that if it goes like a level above 15 milligrams, it can lead to more toxicity and later on neurotoxicity, a cardiac, and where the deposition will be in the basal ganglion and patient can be disabled later on with Wilson's disease and other things like that. And another thing is that if this toxicity is not leading to neurological side effects, but still it is persisting and it is not being treated. Now the patient can have delayed developmental defects and delayed mental retardation, which will be of a very mild variety, like the child will never be a best at school, and he will have all the developmental, like walking, talking, everything will be delayed. So this can be a chronic toxicity of bilirubin which needs urgent attention and has to be treated there. So this was actually a guideline, but I think you will get a CD and you will get other things which you can go in details. The age of the newborn is important. If it is less than 24 hours, look for pathological causes, very important. If it is between 24 hours to 2 weeks, then it could be just physiological if it disappears in 3 to 4 days. But if it doesn't disappear, then of course you have to look for other causes, and the levels and other things I have already all mentioned here in details. And if the time is more than 2 weeks, then you have to think for more drastic conditions, like you have to go for a thyroid profile, you go for metabolic disorders, or the patient may be having like congenital defects of biliary atresia or other things. So it not to be passed up that every newborn with jaundice is just going to be normal. Right, so that's okay, thank you. If you have interest.